is well known because he's the chief medical officer of Erlanger. You know, I always say that when I invite old friends to come, and especially people who've that I've known throughout my career, that I was thankful for many of them not crushing my career when it started. Well, now the shoe's on the other foot. Theoretically, I could have crushed Dr. Jackson's career before it started, because he was after graduating from Stetson in Florida, he was a medical student at Tulane University in the 90s when I was a faculty member there. I don't know, did I ever lecture? Did you ever? Did you ever? We interacted? Frankly, I don't
see how memorable I was.
Yeah, whatever. Another medical student, you know how that goes. Sorry, guys. But he from there he did his internal medicine residency and critical care fellowship at Walter Reed. Was in the Army serving as a critical care medicine doctor and telemedicine specialist for a number of years. I think then went to Inova Fairfax, and where he was a critical care medicine doctor and got involved in administration. Obtained a master's in business administration from University of Virginia School of Business, and then was successfully recruited here. And I guess you've been here 3.5 years, and really has made a big difference as far as I'm concerned in physician's practice and quality, and basically been a big supporter of the residency program. So I'd like you to welcome Dr. Jackson and thank him for speaking.
Thanks, Lou. Is this on? Everyone hear me? Mike, can you hear me on this? Okay, great. I want to thank Lou for the remarks. You know, I don't know how many house officers and students there are here are going to be coming in that, you know, you don't look and see how your career is going to go into the future. None of us have a crystal ball. It's, you know, all, you know, sovereignly decided in my view. But, you know, 25 years ago, Lou and I were together when I was a student. He was one of the most highly esteemed junior faculty, truth be told. So to think that now I'm presenting Grandrounds in his department is actually, it is a privilege for me, Lou, and I do want you to know that. I want to state that publicly. That said, I do want to temper expectations a little bit. First off, you know, Lou texted me about 2 months ago and said, you know, we have Grandrounds opening. Do you have anything you'd like to say? And, you know, I have a lot of things I'd like to say, but probably none of them are appropriate for this forum. And I thought to myself, you know, it'd probably be good for me to contribute a little bit more than I'm doing right now, because Lou is thinking he's got a full professor who's not attending. He's not really teaching the way that he should. Maybe, you know, he can fill in one of these slots. And so, you know, to the degree, this title in particular, a lot of you think this is something from, you know, Ulysses or a Smith song. You know, the simple fact is, you know, I think there are some useful things that I can say about the time that I experienced when I was in practice, when I was one of you, and when I was, you know, actively looking at the literature in a way that you guys do on a day-to-day basis now. Secondly, I do think it's worth pointing out that, you know, as a long-standing member of the administration here, you guys can just view this as you see it. You have a full professor who has now been unleashed and is going to speak to some of these things. And if at the end of the day it doesn't work out, you can essentially put me back in my administrative cage. And I'll speak on those things that are more germane to administration. So 3 points I want to make right up front relative to what I'm not going to talk about. The first thing is this is not going to be a contemporary review or update on sepsis specifically. Unfortunately, I'm out of the game in that sense, and there are people on the faculty, including several I see in the room right now, who could speak to that much more articulately than I could at this point in my career. Secondly, this is not going to be essentially an update on how to review the medical literature. No user's guide to the medical literature here. That is foundational. That's what we all need when we're going to evaluate studies and trials and those things that we apply in our practice. But again, I would be out of my depth in speaking on that. And thirdly, everything I'm going to present is in the public domain. This is some of this we lived. I mean, I know Dr. Setti in particular, given where he is in his stage career, is going to, I think, reminisce on some of this. I'm in no way trying to impugn or do any character defamation around the authors or the the trials that are represented here. I think people who are in academia try and do the best they can. Certainly there's influences, there's biases, and I'll speak a little bit to that. But the only anecdotes I have are going to be ones that are somewhat peripheral to the story at hand, and there's no intentionality on my part in terms of having some preordained knowledge about how financial influences came into play in these trials. So what is it, if it's not about that, what is it about? What I think I can offer is a few things. One is I was in active clinical practice, both on the academic and community side when a lot of this went down. Secondly, I've been a program director. I've sat in many of the shoes you're in. Certainly I've trained, but I've also overseen trainees, and a lot of what I was teaching around during the time when these trials came out was guided toward fellowship where I was a PD and house operators that were in the ICU. Thirdly, I have published, albeit very peripheral to the story at hand. I'm going to shamelessly refer to some of my own work, but it was very, very esoteric relative to the issues at hand. And then fourthly, this is somewhat of a mea culpa. Maybe it'll be somewhat cathartic for me because it will allow for you to see where I made errors in judgment that impacted my practice that over time, I think the literature bore out was very different. So that said, financially, I don't have any interest in this. I don't have anything to say about it other than I'm going to point out some issues where those interests were there. I'm sure Lou has a lucrative honorarium planned for me after this talk. This is the outline. This is what I want to go through. And really the main trials, which again, Dr. Setti and some of you in the room who are more senior are probably familiar with, Xigris, early goal-directed therapy, and intensive insulin, how that impacted our discipline in particular, but I think intensive care, delivery with cardiology, trauma critical care, surgeons across the scope of what we do in the ICU. Talk a little bit about the fallout that came from that, and then I'll touch on some lessons and implications around that. Again, this is, in my opinion, it's a grand rounds, but it's interactive. If anyone has questions, you want to shout out, if you've got comments, I'd like for this to be as collaborative as possible. So a lot of what I'm going to talk about here has essentially historical context. Like I said, I'm not going to give an update on sepsis. It'd be out of my depth in talking about it. There's been some migration of where service criteria has gone to now SEP 3. And so there's a lot of discussion around there that would be best referred to Dr. Koo, Dr. Setti, and others. So the context I'm giving here was the prism that intensivists were looking at as these trials came out. So Derek Angus and his UPMC were JIGME trained, and others produced really a large-scale epidemiologic study of how sepsis was in the 1990s, and a lot of the study was from the 1990s. And this was good because it gave some perspective on what we needed to do to invest in sepsis and to try and change the direction the country was going in terms of the numbers you see here. So obviously there was a neonatal peak, still is. There's a peak that you see as you get older. But at this time, it was probably upwards of 900,000 cases between sepsis, severe sepsis, and septic shock annually in the United States, with the disease burden rising as you get older. And that hasn't changed. There's probably just more because there's more Americans now. In addition, the cost was in the $15 to $16 billion range. Again, higher now, but it was just as much a scourge then as it is now. And you can see, again, a neonatal predilection as well as an older predilection. The nice thing was it would seem even in sepsis at this time, the total national cost, if you look at those who were septuagenarians and above, the trend would still trend downward in terms of what we're doing with end-of-life care. So maybe some hope for that, even though we know oftentimes the care we deliver is futile, despite our best efforts to educate the population we're treating. Again, a contemporary review from Wheeler and Bernard out of Vanderbilt at this time gave what probably looks like a fairly simplified explanation for what sepsis is, given what we know now. But the sum of it is you've got a toxic stimulus, again, essentially an infectionitis, some pathogen. You get, and this is just a couple of many cytokines and other factors that would cause adhesion. And the main, really, part of what happens with microvascular disorder, microthrombosis, with a lot of these mediators that will come into play. Again, this is admittedly a review article from New England Journal. It was simplified. It was geared toward a particular audience. But truth be told, when you look through the depth of the literature in our subspecialty at the time, there wasn't a lot more knowledge around it, and that'll become apparent as we go through some of these trials. Another article by Hotchkiss at this time showed, again, a perception on the basis of how we might apply some of the science that was known relative to immunologic response, looking at a healthy person who would get a hyperimmune response, Lord willing, over a 3 to 4 day period, if resuscitated and treated appropriately, would do fine. We see that when patients get essentially a magnified SIRS response nowadays. Elderly patient with malnutrition diverticulitis might have some degree of attenuated hyperimmunity over time. Again, a longer course as a result, and they might recover. And then a patient with comorbidities, the thought was, well, they may not get that hyperimmune response because they've got already immune modulation that is going to drive them in a different disease course. Again, this is very simplified. Probably is not that different from where we are now in terms of the science we can apply, but conceptually this was very, very novel at the time. Definitions, as we know, and any of you who have been discussing this in the MEC and are part of our sepsis committee here know this continues to be the bane of everyone's existence. It's been around for 30 years. Bone was really a giant in critical care. And they did the best they could during this time to say, how can we define something that might allow for some degree of standardization and the ability to allow for some homogeneity in clinical trials. Sepsis, by definition, as we all know, is a very heterogeneous disorder. But I think the rationale at the time was to try and say, what is it that is going to give us some early template to look at this hyperimmune response? Sorry about that. This hyperimmune response up here. And these things, again, would suggest in certain people, you get fever, you get hypothermic, your heart rate goes up, respiratory rate goes up. Everyone in this room knows it because we're looking at it. Many of you are getting sepsis alerts throughout the course of the day because you're in the EHR relative to it. So the definitions, again, SIRS plus documented infection, everyone knows that. Severe sepsis, sepsis plus organ dysfunction, and then septic shock. This article is a landmark in the sense that it defined this, but also in that, it gives, in hindsight, in retrospect, the ability to look and say, this is really something that people were trying to do on the fly. Multi-organ dysfunction syndrome, multi-organ system failure was described as part of this article in terms of how we could start to examine those patients that had evolving sepsis, severe sepsis, and septic shock. The term CARS, I don't know how many people have used this in clinical practice. I have not. Maybe others have. But this was described, defined in here as a compensatory anti-inflammatory response syndrome, trying to capture those patients who had comorbidities that really didn't meet early sepsis or SIRS criteria. MARS, again, never really used in clinical practice, at least in my clinical practice. Maybe in others more sophisticated at UPMC. They don't might have done this. And then chaos, which was really reflective of the thinking at the time. And again, you'd think I was making this up, but this is actually, again, taken directly from Bone's article, speaking to different areas where really there was just, I think, really a confessional that we didn't know exactly what we were talking about. How can we take what we do know from the bench and try and apply it to people who are doing the best they can to resuscitate these patients at the bedside, knowing that it was a huge scourge in terms of cost and outcomes. So a lot of this early science that was done led to treatment alternatives. Okay, so the early studies that were done were promising. The problem is the population was heterogeneous, even despite the definitional criteria that were developed for SIRS. And we even know that again in clinical practice today. There were surrogate endpoints. People were looking at what some of these compounds might influence in terms of inflammatory mediators, certain things that they were targeted to address. In addition, these were admittedly underpowered studies from the get-go. They were talking phase 1 studies, phase 2 that they were trying to use in a very complex disorder to try and say, here's something else that can be used to apply this to the bedside. Admittedly, there was probably an element of profit motive around it with the medical industrial complex because this is what drug companies get paid to do. So in the 80s and 90s, there were a lot of studies to this effect, and the definitive evaluation, like it is for pretty much every one of our disciplines, is to do the randomized double-blind placebo-controlled trials and then look at 28 and 30-day mortality, not to really look at those things that were going to be surrogate endpoints. And the issue became that it was really a broken record, and I'm just going to give a handful here. And that expands from really 1994 to 2003. These are some of the prominent ones. These were in the preeminent journals. This was interleukin recombinant that was applied, and really there was no difference here. You look at E5 monoclonal antibody. This was in Critical Care Medicine by Bone, again, the author of the original criteria. No difference here. TNF-alpha, the monoclonal antibody, again, thinking that would apply it. This was another one that was hypothesis generating. You see there might have been some change here in septic shock, but there was only in that subset. You look at all patients. Again, this was not something that was thought to be universally applicable. Delta bond, Again, applied. This was an immune modulator. Again, a study, no significance. Added, again, more to the nihilism of the times. Ibuprofen was actually looked at. It's a New England Journal study by Gordon Bernard, who, again, was at Vanderbilt, subsequently did one of the studies I'm going to speak to at length on. Really no change. And again, I thought that when you have such a complex disorder that is defined by chaos, is going to be impacted by ibuprofen, probably was a little bit of naivete from the start. Easy for me to say in hindsight. Kybercept, again, antithrombin 3. Important to point out, antithrombin 3 impacted that part of the coagulation cascade and thrombosis that was thought to impact microvascular issues in patients with sepsis. Again, largely powered study, but ineffective. Tifacogen, which was the first of the cogens. Again, I'll allude to that in a little bit. This was a recombinant tissue factor pathway inhibitor, again, shown over 1,700 patients to be ineffective. GCSF actually was applied in these patients, thinking that we might improve the white count, try and look at some of these surrogate endpoints. That might help, ineffective. And then my favorite, LY315920, NAS5920, which was equally, again, found to be ineffective both in low and high doses. So all these always had caveats. There was always these surrogates that we were on the cusp of trying to do something bigger. You can see all of the hedges that were around it. However, this might be safe, appeared to be safe, might have some effect. So the ongoing dialogue during this time was, you know, we really don't know what we're going to do, but we're still trying to find something that might be useful given really the futility of sepsis therapy today. And so Jochicogen alpha, again, another cogen, which was subsequently marketed as Zygris, came on the scene during that time. And so this was a recombinant human activated protein C, and I'll show a specific slide in a minute that talks to where it was thought to have some unique capabilities. It is an endogenous human protein, as most know. It actually, the levels do decrease in sepsis. So the thought was, similar to all those other things that you've seen before, this might be able to inhibit thrombosis and inflammation and modulate the coagulation cascade. It was part of the cogen class, which was very brilliantly derived from coagulation and inflammation. It's a 96-hour, was, I should say, 96-hour infusion. And at the time, this seems like peanuts today. Okay? 20 years ago, this was very significant. They did some modeling around it, and again, in the study I'll show. And some of the preeminent large volume centers that were going to be treating sepsis in this country was going to be upwards of 10 to 20% of their formulary at that time, if it was applied to all those that the Prowess study was subsequently applied to. To keep that in mind, TPA at that time was around 2,000, and this was again in an era when TPA was infused often and early for myocardial infarction. So if you look here, again, part of what they felt was different here was that it had different responses that you didn't see in some of these others. It inhibited, again, tissue factor release whenever you had the endotoxins, stopped interleukin-6 and 1, tumor necrosis factor alpha, again, both immuno-excitable and those that would modulate and lower the immune response. Also had a thrombotic response to infection, so impacting those factors that would lead to thrombosis and fibrin formation, and then it would break down PAI1 and inhibit suppression of fibrinolysis. So it was thought to have a salutary effect across all those things that impacted microvascular problems and sepsis. So the Prowess trial came out in March of 2001. This got a lot of play at the national meetings. It was really explosive, if only because there had been this history of the past decade where there wasn't success in driving outcomes in sepsis. Again, it met what we would consider to be a gold standard for a large trial of this type. It was multinational, almost 1,700 patients. And again, when we looked at the values, statistically significant, a 6.1 absolute risk reduction in terms of dying, which was an outcome that to that point had not been achieved. Now, because of the way that activated protein C worked, there was a caution around bleeding. And it approached, again, given the arbitrary p-values that we use at 0.05, it approached what we would consider statistical significance, but that was known to be a potential side effect or complication given how the drug worked. If you look again, the thought that was published in Prowess was there was a breakpoint early, this continued out over time, and that at 28 days, you saw that mortality. So over time, it was salutary, even though that was early on in the days of the course of the infusion. And as I mentioned, it was a 4-day infusion. It was continuous for 96 hours. And the number needed to treat to save 1 death was 16 per the Prowess trial. In addition, the risk profile when we looked at bleeding, again, approaching serious bleeding events, and you can see them listed there, was 66, essentially patients treated with 1 bleed. Of note, and it was pointed out by some of the authors and speculated by others, that if you look at intrathoracic and retroperitoneal, given the nature of how we're treating these patients, given how they get access with femoral or subclavian or IJ access, this might have contributed to the fact that patients that get lines, if they're given anticoagulants, are more likely to bleed, and if you take that away, it might have limited the difference you see between those 2 elements. So something that was, again, taken into consideration and used to explain some of the effects that we're seeing. I'm not going to read this, and I don't expect you to. This was merely shown because there were a lot of exclusions. When patients were enrolled in this trial and was brought forward and marketed, there were some concerns to say, is this really the patient population that we're going to be treating in large volume centers and in community hospitals across the country? So in hindsight, Michael Mathey put a contemporaneous editorial that looks very tempered. I think it was appropriate at the time in terms of him speaking to the history that we've been through, people not knowing exactly how immune modulation and sepsis work, how it could be improved. And again, I think the most emphatic statement that was made in the editorial that accompanied the original study was that evidence had been provided that mortality could be reduced. Okay? Which again, given the marketing and everything that went on thereafter, was I think was relatively muted. So it wasn't long after that, recall that Prowess was published in March as a lead article in the New England Journal, and then subsequent to that was presented in a lot of national meetings. So what was started to present in journals, and there may be some junior medical students or people in the room that don't know, given how the EHR makes us code at all hours at night, a lot of what intensivists would do after a long day was they would go home and read journals. Okay? This is what we did. And so Lilly was putting out here sepsis, new insights, but again, it had this Lilly critical care, which was I perceived a lot of people to be a prelude to the Surviving Sepsis campaign. Really, only in the corner here would you see some reference to Eli Lilly and Company. Although, again, it was boldly stated here, but the whole idea that there was an element of this new approach to sepsis appeared somewhat insidious, certainly after the fact. Just in September 2001, again, more of the same. New insights, new outlooks. How can we look at this, tying into those things, known or suspected infection, elements of SIRS, 1 or more acute organ dysfunctions, i.e. the inclusion criteria for Prowess. These are things that were marketed directly to intensivists across the journals at the time. And again, Eli Lilly was behind it, although these are not things that generally as a clinician that you're going to look at, even when you're hearing all this other noise around how the trial was run and where the exclusions were. So in January 2002, this was in CHEST, and essentially, most of you might say, this looks pretty innocuous. You know, this is just, it's now available. You've heard around all the trials, everything's come up. They put out some other, other advertisements. This doesn't look like something that's going to be particularly riveting to someone who's going to prescribe Xigris. What a lot of people don't know, I think Jigme might be able to speak to, some of the others in the audience who practiced during this time. This was a very, I would say, probably fearful time for intensivists because, number one, the mortality was so high. Number two, as I've already shown, there were a lot of studies that were ineffective over the course of a decade. And number three, as I said, when you would go home, you would just read journals. This is the type of thing you'd see, and this looks very comforting and soothing, particularly because in this same edition of CHEST, you had, and this is all true, this isn't all these things at the same time, you had things like this. This looks like it's innocuous, but this is like where the wild things are type of thing, arousing you and keeping you from getting any rest. Same edition of CHEST, you've got a huge stop sign with kills in the corner that's arousing you to, the futility of what we're trying to do as intensivists. You have the Lovenox Great White coming at you with killer, again, same Journal of CHEST. Later on, you've got Strike Back Now, this Viper from Mass Effects. It was no wonder that intensivists were looking for something that they could hang their hat on. Here you've got an intensivist, again, the next month in chest, who is clearly exhausted. He hasn't been able to sleep. He's tired. He's got a nurse. They're trying to work through what they can with this patient here. And the answer is now yes for sepsis. So introducing Xigris. So admittedly, and again, I was taken in by this, you felt soothed. Lovenox shark comes back. Here we are just when you thought heparin should be working. And then this, which is really takes the cake. This was in April. This is like the unholy trinity, where you've got blood, you've got killer, you've got what looks like Stephen King's It and the Blair Witch Project tied together. It was really a very difficult time. So they were hitting nurses as well. You look at nurses, February, October, February, April. There was a lot of marketing around Xigris and how this might apply at the bedside. And so as intending, I actually did prescribe a lot of this. It was at Walter Reed when I was there in the 2001, 2002, 2003 range. And a lot of what we see is what is, I'm going to allude to, is what subsequently came up in the literature. So those patients who had Apache scores that were higher, and again, I'll touch on that in some articles that came out subsequent, younger patients, got it early. Again, not unusual now what we would think around early therapy for sepsis. Generally live 19 days. Those that expired, again, this is mean, this is a small n, this was just the experience that we had at the time. And the nice thing about being in the federal government at the time was there was not a lot of scrutiny around the budget. So we didn't have any cost constraints around this. We had to make sure that there was a certain Apache score, and then we had to prescribe it as we saw fit. But in September of 2002, so this is about 9 months after Xigris had been on the market, there were no fewer than 6 articles, 2 admittedly were letters to editor, but 6 articles that addressed some of the issues that were going on essentially behind the scenes relative to Xigris. And so Warren and colleagues spoke to this and said, we want to give some information. It's not in the prowess study. It's not in the marketing literature. Now, the vote at the FDA on the Anti-Infective Drugs Advisory Committee, this was supposed to meet on September 12th, but obviously, the atrocity of September 11th happened the day prior. They moved it back, and it was split 10 to 10. 10 people on this committee said we should approve this drug. The other 10 said we don't recommend approval. And the thoughts were, that came out in this New England Journal Summary, was number one, the protocol was amended. I'll go over a couple of these things on the next slide. Protocol was amended to make sure that we're including patients that had more acute disease and fewer comorbidities. Unfortunately, a lot of patients that we see with sepsis have comorbidities, and they were not excluded initially in what was shown in prowess. The placebo was changed from saline to albumin, which again, those that are familiar with critical care trials knows there's some suggestion that that might make a difference. The recombinant human APC master lot was altered, so they completely changed that halfway through the study. Now, a lot of the in vitro testing that they did subsequently suggested that was not an issue, and Lilly said we've got enough of the APC and the master lot now to do this for the next 30 years. But the argument was this kind of tainted the trial in prowess somewhat. And then the post hoc subgroups they did said surgical patients, you only have one organ failure, and if you're not that sick, if your Apache 2 is less than 24, this probably was not that beneficial. So if you look here on the slide, what Warren and colleagues pointed out was that the version of protocol was changed in line A. And what it did was, again, it moved more towards those who had fewer comorbidities and looked at admitted patients who had more what they thought were purer infections. All right? First interim analysis occurred here. Up until that point, there was no statistical significance. In addition, at this time was when they changed the placebo. It was around A. So when they changed the manufacturing, the placebo, and those elements of the criteria with the study, that's when you sought to see this split. And then the interim analysis, the second one, stopped here. Okay, so they stopped this trial early on the basis of a change that really happened, according to Warren, their argument was in the second half of the study. If you also look here, what they published as well was what was substantiated, what we had seen at Walter Reed as well. Namely, you're sicker, you probably did better with this drug. But if your Apache score was less than 24, the placebo group actually, and particularly for those that were low, 319, their mortality was higher if you look at this entire aggregate. So they concluded there's not sufficient evidence for precedent for it to become standard of care, even though this is, again, on the market, had been, I think, very liberally prescribed over that time period, and certainly Lilly was marketing very heavily. Now, there was a counter view in this from Siegel, who was part of the FDA at the time and part of that review. And he pointed out, listen, the trial elements that were changed when we got rid of patients who had chronic health points on Apache 2. So those that, again, we eliminated the acute physiology and chronic health evaluation, for those of you who don't know the acronym, although we all use it. Those who were sicker at baseline, okay, they excluded those, but the absolute difference in mortality was better in those patients who were sicker by chronic health evaluation points, not just their physiology when they came in. Siegel's argument being, what they did should actually have made the trial much more toward the null. Instead, what they did made it more favorable for those people that would otherwise get the drug early on. And in addition, there were some changes, but he did affirm essentially your quartile of Apache score. There was a bigger difference in those that were sicker. Same edition of the New England Journal, there was an economic evaluation. Key thing to point out here for cost-conscious pharmacies is that if they were less than 24, the cost quality of adjusted life-year gain was almost $1 million. All right, if you compare that to other things you're looking at in our industry, that was particularly high. So they said, you know what, reasonable to restrict this. The argument, the problem that came out after that is that we had never, in critical care up until that time, triaged patients and delivered therapy on the basis of Apache score. Sure, we would know who was sicker, but there was no way to discriminate amongst those. And so in addition, they said, and this is probably reasonable for anything in our industry, to target the patients who didn't have coexisting conditions and substantially limit life expectancy. And that's actually where the change in the protocol occurred halfway through. In addition, studies, those of us who have been to business school, you're numb to these things. These things come out all the time. Eli Lilly Zygris case, how they were marketing came out. They were very intentional around what they were doing for surviving sepsis. One excerpt I found somewhat amusing in this, and thankfully this expert was not named. It creeps up on you like the Grim Reaper. So if you want to know how people with MBAs view doctors a certain way, it's because we're putting quotes like this to describe drugs like Zygris. In addition, this is the sepsis progression, which honestly, when you look back on it relative to what we were putting out at the time, was probably not that much less sophisticated than what we knew. What came out that was very interesting during this time, again, about 4 years later, tied to the Surviving Sepsis campaign. These three authors, Eichaker, Nakens, and Danner, were NIH clinical center attendings. At Walter Reed, we actually did rotations through the clinical center, and this was just one small anecdote around that time. Rounds at NIH were unique in that there were a lot of complex malignancies that would come in. The unit itself was only 8 beds, so it was small. But there were disease states you would never see before or after in your career. So every time you were on rounds, it was truly zebras that were approaching. It was very rarely horses. So everything was turned upside down. In addition, the researchers there were very prolific. Between the 8 senior attendings there, they probably published between 12 and 1,500, including, I'm not talking all those ones that co-authored, articles on PubMed, but they all came to rounds. So if you were presenting on rounds, you essentially had these 8 geniuses peppering you with methodologic questions. It was really very pleasant. And I look back on it favorably. But the thing about these 3 in particular, and some of you may know, Jigme probably knows this, others may, around this time, the ARDSNet trial came out, around 97. And so ARDSNet, and many of you know, compared low tidal volume ventilation to high tidal volume ventilation, or what was considered high at the time. And showed a difference, which was beneficial, and a lot of practice changed. The argument that Eichaker and colleagues made repeatedly was that that practice had already changed, and via meta-analysis of studies that had been done previously, ARDSNet should never have been performed. So there was a lot of sparring back and forth already within the literature with a lot of the faculty at NIH and those people that were actually doing the trials. So this further inflamed it, and again, you can see why. One is they said, again, a lot of this is being moved into the surviving sepsis. Now we're putting in bundles. Now, legislatures and governments and regulators are going to say we need to hit this. And the simple fact is, who's overlooking what's being generated with this? And again, alluded to possible industry influence around it. They pointed out that for Zygris, originally the FDA already required additional subgroup testing. All right, so that impacted sales negatively for Zygris, and they had to change their marketing strategy as a result, and a lot of that came through them looking at Surviving Sepsis campaign. They said, when we do this campaign, you put this forward, you're going to be collaborating with the not-for-profit arbiters of quality, so AHRQ, Certainly the societies, with the exception of the Infectious Disease Society of America, all were on board with this. And they felt, listen, you're co-opting this for a trial that is flawed. And again, you can read that. They felt, again, in a very inflammatory way, this is marketing and masquerading as EBM. And again, what they showed this, in this paper, again, was published prowess, sales begin. They targeted 300 to 500 million. And they were told they needed to do similar studies at that time. And they were low during this period of time. They were not hitting the targets they had internally gotten. Some of that was actually in the Kellogg Harvard Business Review article I talked about, where they had set targets that were much more ambitious. They originally viewed Xigris as a $1 billion annually drug. And so this one, I mean, this comment, again, you guys can read this, is really something that I think spurred on a lot of interest within academia in our subspecialty. Namely, they're doing marketing initiatives through physicians, medical trade. I've showed some of that. Okay. But then they said, you know what, this is going to be systematically forced on who's going to live and who's going to die. We're going to have to ration this. We need this promulgated through a Lilly marketing arm. They gave a grant, formed this task force, and then lastly put the Surviving Sepsis campaign. Now, as far as charges go relative to questioning someone's intentionality, this is pretty, I think, pronounced for what you'd see in an academic journal, particularly in the Journal of Medicine. In addition, what was intriguing to me, having worked with these guys, was they talked about here the sepsis management published in Critical Care Medicine in 2004. The third author on here, Henry Masur, actually is one of the world's foremost experts on HIV, is an intensivist, and was the senior partner of these three guys. So essentially, they're calling out each other now in the medical literature relative to how their dealings are going. Now, immediately there was a pushback. Philip Berry, who was a big surgical intensivist, said, listen, you know, these guys flogged everything on Zardsnet. They flogged everything here. New England Journal, last two editors have had books that essentially rage against the medical industrial complex, but again, they're paid for those books. Charles Durbin, who was the past president of the Society of Critical Care Medicine said, you know what, if we don't get some money through industry, we're not going to get money. The year that Surviving Sepsis was developed, federal government funded AHRQ to the tune of $50 million to try and look at outcomes research. Everyone's going to groan, but that money was subsequently diverted to health IT. So none of the money that was earmarked to try and support development of sepsis guidelines was there. It had to be viewed from industry sources. And then there was a lot of discussion, again, relative to, is industry really influencing this? Surviving Sepsis campaign, and this, again, is a live website. This is where these things have come out. Has a history. It was inception in 2002. And they don't speak specifically to industry influence here. You scroll through it. 2008, they talk about the history. And then the ISF, which was the thing that bankrolled it, left to avoid any misconceptions about the industry involvement. So unfortunately, this influence really has shaded where we were with a lot of things relative to this. Early goal-directed therapy, again, this was later that year. All these three trials were in 2001. I think most people in the room are familiar with this. At the time, the key things that were pointed out, this was a small trial. It was a single center. The mortality in the control group of 47% for all comers for sepsis and septic shock was probably higher than what we'd seen in the literature at the time. So the question was it much more the effect of the treatment arm, or did they have an unusually high N dying in the placebo arm? Key thing to point out here that was subsequently pointed out by many authors, including those tied to Surviving Sepsis campaign, was this was a very meticulous and I think well thought out protocol that, again, many readers, including myself, subsequently ended up applying. But the point around it was they evaluated 288, and they enrolled 263, and then the intention to treat analysis excluded the 25 patients that were here. So there's a lot of debate and discussion around that because it might have skewed the trial differently in a way that was not nearly as favorable to using early goal-directed therapy. Moreover, a lot of the things that were in this guideline. So a patient comes in, they need to be getting oxygen or intubation, you get that. You need to catheterize them, you do it. A lot of the things that were described here actually contemporaneously were being brought into question around individual interventions. So in the aggregate, why would they be useful if they were not necessarily good? One, CVP. We measure CVP, we all know on the basis of where someone's ventilated, what their volume status is. It's a very inaccurate measure of what someone's true intravascular volume status is. SCVO2, a lot of studies, mostly in the surgical literature, that again, I'm sure Dr. Moore, Dr. Dark could speak to, spoke to oxygen delivery. A lot of that work was done in the 1980s, and it was found to be ineffective. Inotropes, again, use of dobutamine in particular, it was not up until that time considered a standard in sepsis. And then transfusion, again, at that time, to be fair, was coming out to be more thought as poison than of considerable value. The TRIC trial came out in 1999. Again, to be fair to Rivers and colleagues, that trial did enrollment from 97 to 2000. TRIC trial, which everyone knows, looked at hemoglobin of 7 versus a hemoglobin of 10, showed 7 to be essentially equivalent around it, only had 41 sepsis patients. So the argument could be made, albeit implausibly, that transfusion might still be beneficial in sepsis to guide someone over 10. In addition, Andy Shore and I published an article at this time. I point this out only because we were pointing out that transfusion was a problem, and this is probably even today the most preeminent article in the medical literature that talks about Pink Floyd. Subsequently, a much larger study did look at this specific study. So if people are going to say, well, those with cardiovascular disease, those with different disease states versus septic shock, transfusion might be different in those. Again, not that Rivers would have known this 13 years in advance, but it's subsequently been shown to be the same in septic shock. Transfusion thresholds that are lower are safe and equivalent. Of interest that was pointed out by many at this time, Dr. Rivers was a paid consultant of Edwards. Edwards was trying to develop and promulgate a catheter that was based on early goal-directed studies. Interestingly, Dr. Rivers did trademark early goal-directed therapy in EGDT and was, again, early in developing this catheter. Now, they provided the rights to where he worked, Henry Ford, so he divested of this. Again, the trademark, you can find it. He had it up there. Did it in 2004. 2012, it was unrevivable for EGDT. You look at early goal-directed therapy. Again, he put in a patent for that, or trademark, excuse me, and again, 2004. It was, which I find somewhat ironic, this was abandoned for a failure to response, which is really amusing in the context of early goal-directed therapy, and that being a trademark. Interestingly, again, we published another study, and again, this is where I'm somewhat culpable in trying to give some degree of mea culpa around it. We published a study that was based, Andy and I were at Walter Reed at the time. Scott Mysick and Merrick Holliff were at Washington University, still both are, I believe. And they looked and did a before-after study on the basis of the Rivers study and said, how do we apply this, and found it to be beneficial in our institution. We went and did a look back, looked at the outcomes and cost, and thought, at least at this study, again, small, this is about 270, 280 patients, that it did lower costs and was of benefit. So actually, Rivers and colleagues started citing our study to defend what they were doing in terms of promulgating their catheter. So intensive insulin study, again, I think everyone knows there's a thought that hyperglycemia is bad. The question is, normal glycemia good? And so the authors that developed what's called the Leuven protocol surmised that if we normalize this, it'd be better. So Vandenberg and colleagues, this was, again, a Dutch group, looked single center study, again, keep that in mind, 1,600 SICU patients, and found that mortality was reduced considerably. Again, powered reasonably well, but some things came out subsequent to that. You see where the curve split. Here's where the Apache scores are, and again, it was regardless of what your severity of illness was. Whether you were not sick or whether you were sick, you benefited from having your sugars managed very tightly. So what was really interesting in this, and then again, in hindsight is easy to find as implausible, is one single center study that had about 63% primarily CT surgical patients could do all of these things. Not as much risk renal replacement therapy, critical illness polyneuropathy, which again, you see if you look for it, but it's not that endemic throughout an ICU at any given time. All these things were considerably improved just by using this. Interestingly, again, all patients received IV glucose at the time they came and got the insulin infusion. This was not something that was considered standard of care at the time. The editorial, I think, was appropriately muted. It said you can't extrapolate this to patients in non-surgical ICUs. Widespread adoption would be premature. That doesn't mean it wasn't adopted. Again, I think other people in the room could also speak to this. In addition, a few years later, and to be fair, these authors had developed a insulin system in the 1980s and 90s. Just so happened that when the Leuven protocol came out and was a frontline study in the New England Journal, they went and published and said this is where it might be beneficial. They then got into a fight with Glucotech, which essentially produced a similar model for insulin control and called it the glucomander. And then subsequent to that, they were joined Glucomander, they owned stock in Glucotech, and they had an ownership interest in Glucomander and published their results in about, if I recall, the study was around 250 patients. So a small study. It's really the only one on this topic since that time. And now Glytech, which is the parent company of Glucotech, owns the Glucomander. So again, a tie into industry. I'm not indicting any of these authors. I can't indict any of these authors. I don't know any of the particulars around it. But it should just, it's worth pointing out, and I'll touch on this near the end, that these influences matter in a way that we need to have some degree of pause, particularly when we're seeing certain studies of these type. So what came out, particularly with a lot of the studies? One of the things that was beneficial to this is there were a lot of subsequent studies that had, names and acronyms that would make cardiologists blush. First thing was, a lot of people realized this is complex. I mean, yeah, we already tried AT3, it didn't work. We tried TFPI, it didn't work. RHAPC, we said worked. Why would that work if that was where there was coagulopathy? And we were realizing things were much more complex when we were using these single bullet type therapies. So at this time, ADDRESS came out. Again, this was around 2005. This was one of the studies that the FDA mandated occur. This was very painful for me because I spent about a year at Walter Reed trying to get this up. As soon as we were approved to do it, within 2 weeks, the trial was stopped for futility. So it made me realize the futility of trying to do that type of research in the Army. And so it was a benefit to me in my career. Of historical import, Baroness was actually a site for the ADDRESS trial and did enroll patients here. So this looked at the low acuity population, was stopped. This was then looked at children. Again, the FDA said you've got to look at this before you ever market it use in children. You need to make sure that it's applicable there. I looked again, and you see again the RESOLVE trials, what this was titled, with again a nice funky acronym around it. 477 patients, looked at patients that were sick. These are sick kids. No difference in 28-day mortality. The PROWESS SHOCK trial, again, was published in 2012, came out. A lot of the same authors that were behind the original PROWESS trial stayed on and assisted with driving this one. Again, almost 1,700 patients. The 4-hour support early on, patients who were appropriately randomized got either large volume fluid responses or vasopressors, so they were truly sick patients. No difference in 28-day mortality. And so Lilly announced Xigris would be withdrawn right after those study results came out. Some of the things, again, we believe the original approval is appropriate. These recent results were quite unexpected. Again, that was viewed with some skepticism. Look at early goal-directed therapy. Again, PROCESS was a trial that came out. Again, a lot of the arguments, although it was probably beneficial to say we needed to do things earlier, as Rivers and colleagues up at Henry Ford showed. When you looked at it more broadly, bigger populations, was termed protocol-based early goal-directed therapy versus protocol-based standard therapy versus usual care, just less resuscitating as well. Always have no differences in mortality. Down Australia, New Zealand, again, a very prolific group that does trials down there. ANZIC's clinical trials did a RISE study, Australasian resuscitation, sepsis evaluation. Again, 1,600 patients. They used the protocol, didn't have any interim randomized arm, and showed no difference in mortality. And then subsequent to that, 2015, many of the people in the room are familiar with the PROMISE trial. Again, large volume study done in the U.S., no difference in 90-day mortality. And they did point out that on average, early goal-directed therapy increased costs, both in terms of response that you needed, use of catheters, prescribing blood, and the like. So they had an a priori meta-analysis that was set up for these 3 studies. It was published 2 years ago, called PRISM, excluded that original process, the protocol-based standard therapy. And again, it's found similar outcomes, higher cost, no benefit in the subgroups. To be fair, a lot of the argument around early goal-directed therapy has been, while not every part of that is beneficial, there's probably been a much more active response based on regulatory, what people have learned from that study, probably with earlier antibiotics, earlier large resuscitational fluids, checking lactates, checking blood cultures. Those elements of the bundle that we know are time-tested from decades, we probably weren't doing as aggressively. So to say that the protocolized arm, usual care probably shifted over the course of the past 15 years in a direction that is beneficial for patients. So that needs to be acknowledged. Problem is, and this is from New England Journal just last month, it still calls into question the motivations and where the surviving sepsis campaign is. So there's still a lot of argument around this. And then intensive insulin therapy, again, a similar story. You all know it and can expect it from the way that my talk is going. 1,200 patients looking at these two. Again, this is on the MICU side. Intensive and conventional in-hospital mortality, again, approaching 40%. This was a sick population. They made out, again, significantly reduced morbidity. Let's make that last straw. Nice Sugar, again, another great title. Nice Sugar was very large, very powered. Again, this was a multi-center study across multiple continents. Increase in 90-day mortality with the intensive and no difference in morbidity. And then when they subsequently did a analysis of the patients who developed hypoglycemia, this really made people's eyebrows stand up. 74% of the intensive therapy had moderate hypoglycemia, and they defined it as less than 70. Okay, I mean, you're really getting nervous as a clinician when someone's sustained under 70, and if 3/4 of the patients are going under 70, I think it calls into question what the original study benefits were. 6.9% severe, less than 40. So again, when we talk about do no harm, it's hard to justify using insulin at this level that they were doing given these results. And again, the conclusions they drew are not surprising to anybody. So in summary, what are some of the things we can take from this? Where do you have vulnerabilities? And again, this is some of maybe some of you in the room have had some of these come into your mind, particularly when you're looking at initial studies. One is clinical desperation. Admittedly, there was not a lot of knowledge. There was a lot of basic science work being done, how much that was translated to the bedside. And there was, again, a sense of nihilism. You had a 40 to 50% mortality rate in septic shock. So anything that was going to show benefits like this was going to be grasped, I think, very avidly by intensivists at the time, and myself included. First glance, you take a look, that's plausible. We're going to give a study. Some of these studies might not work, but if we decrease coagulation and we decrease inflammation, APC may work. Certainly, I think there have been some benefits around the RIVER study and where early goal-directed therapy has been over the course of time, albeit not every part of that protocol is of benefit. I think that's been shown. And certainly insulin, we want to make sure that insulin levels are not high. Hyperglycemia has negative effects. The question is, does changing it benefit it? And some of the authors, Akereg in particular, have spoken to that where we have the normalization heuristic, particularly with intensivists. Patient comes into our ICU, they're sick. As a critical care physician, particularly in this hospital, and again, I have a lot of personal esteem for our intensivists, for our surgical intensivists, for our cardiologists. Those people are taking care of these patients every day. The thought is someone comes to you, they are sick if they come to you in this hospital. And that's the case for most hospitals of this size and complexity across the country. So your initial goal is, well, we need to do something. And if these things are showing benefit to do something, then why not try and do these things? Now, the fact is, we all know normalization of values is not always a benefit. And so that's something that is important to make sure that we're keeping in mind and relaying to our trainees. Certainly, pretty much 9/10 of what I've shown you is from the New England Journal. Okay? Journal is the New England Journal for a reason, but particularly with these early studies from 2001, all of them, albeit in the New England Journal, have been shown to be discredited at their core. So important to keep that in mind. The eminent authors, again, this is just something that we get sucked into. Again, I've shown you at least one eminent author on these slides. But if you look just by example, Gordon Bernard, again, who is a lead study, he's at Vanderbilt. He's been known to be one of the giants in sepsis research over the course of the past 3 decades. Wes Ely, who's also at Vanderbilt, Tulane grad, I might add, is really the world's expert, without any hyperbole, around delirium and geriatric care in the critically ill. John Louis Vincent, I talked about the NIH researchers. As of 2 days ago, you go to him on PubMed, and there's only one J.L. Vincent. He has 1,250 peer-reviewed articles on PubMed. Okay, the guy is very prolific. He's known well with intensivist circles. He's very, I think, revered amongst intensivists because he's very big on intensive care. I'm not a pilot. I hate flying. This was from one of his articles that essentially says, don't tell me about how aviation is any way comparable to what I do. Again, I just find this graphic amusing, if for no other reason that it probably lowers what Sully was doing over the Hudson. But nonetheless, again, when you have people of this stature, as a clinician who you look up to, you're inclined to listen to what they have to say. The trial duration, okay, came out right around that time. We look at intensive insulin study, we look at activated protein study. They're both stopped early. Okay, again, just a snapshot here. This is becoming more common because of how they look at a priori analysis. So a lot of these studies are not subsequently powered the way they need to be. So particularly with early insulin, I mean, you talk about implausibly large treatment effects, particularly in the morbidity side. You need to look at those things with skepticism. And then we do have a lot of faith in the scientific process. We're scientists. We like to think we do X and then we get Y. Many of you are familiar with this article by John Ioannidis, who does a lot of research and publishing on this. This got a lot of lay press at the time. And if you look at it, it's a fairly analytic article. It's a good read. I would encourage everyone to look at it. And he does talk about financial influencing. He talks about where you need to power studies. He talks about how bias is entered. It's a good article for anyone in our industry, and particularly academics, to be reading. But the argument he makes is you just need to have certain characteristics within your trial that are going to be more likely to be positive. And one of his main takeaways is single trials should not form the basis for therapy direction. Okay? And unfortunately, in these 3 trials, certainly in my own practice and in the industry, it did do that. One of the ironies, though, is, again, he subsequently looked at industry-funded versus not profit-funded. This was just last year, critical care research, and they concluded that there's no evidence that industry drives these conclusions. So there was a lot of consternation during this time, and come to find out, one of the experts that looks through this says, you know what, to the degree we can examine this industry, or excuse me, this subspecialty where the trials have come out, it's probably as clean as you're going to get, recognizing this is a high-level meta-analysis. So I appreciate everyone's time. I hope this has been somewhat valuable. I'm happy to answer questions. I find this slide usually makes people not ask questions. So again, appreciate everyone's time, and again, happy to speak to it.
I would agree that a lot of this was born out of frustration in the intensive care unit. People with sepsis died, and there seemed to be very little that we could do about it as clinicians. I would just the Manny Rivers article, for example, when that came out, one piece that perhaps you didn't dwell on too much is that was a move to try to get patients treated in the emergency room because they were having trouble getting them up to the intensive care units. At that point, of course, people put in PA catheters and things like that, but they didn't do it